Ladies and gentlemen, Mr. Chairman, Professor Berger, thank you for the invitation to speak here. It's a great honor to me. The question that I should answer now is which kind of subaortic stenosis responds to resection alone? And when I think of subaortic stenosis, then I think of my training in the Boston Children's Hospital. And the chief resident on the first day, he said, he said to us, to our senior residents, to our group of senior residents, well, you will get all the subaortic stenosis that will be referred. And I was very happy. I thought will be a nice time. And but only 2 subaortic stenosis were referred during this 6-month rotation. So this was a little bit disappointing. So what are we speaking about? The definition of subaortic stenosis means that is a left ventricular outflow tract obstruction below the level of the aortic valve. That means that we don't need to talk about cusps or leaflets or commissures or anything like that. From the anatomy and the morphology, we know that this can be an isolated subaortic stenosis, a fibrous or fibromuscular ridge, or a so-called tunnel type. It can be part of an hypertrophic obstructive cardiomyopathy, and much more, it can occur in complex, it can be part of complex malformations. Well known is the AV canal, then the complex of posterior malalignment, ventricular septal defect, plus coarctation or plus hypoplastic aortic arch or plus interrupted aortic arch. The complex transposition of great arteries with VSD and left ventricular outflow tract obstruction, or double outlet right ventricle with transposition of the great arteries and left ventricular outflow tract obstruction. It is in many cases part of a critical aortic stenosis, especially in borderline ventricles, and it can occur in single ventricle with transposition of great arteries and subaortic outflow chamber. The ventricular septal defect acts as a subaortic stenosis. And it can occur after a repair of complex malformations. It can occur after AVSD repair, after Rastelli procedure, after double outlet right ventricle with intracardiac repair, and so on. The list is not complete. Sorry. So what options do we have for treatment of subaortic stenosis? This is quite simple. We can resect it. We mainly think of simple membrane resection, but this membrane resection should nowadays be accompanied by at least by a myectomy and by resection of accessory tissue and mobilization of papillary muscles and so on. It must be a more radical approach because the subaortic stenosis is in almost all cases associated with anomalous flow patterns. And we can enlarge it with a patchplasty in a modified Conner procedure. We can do the aortoventriculoplasty, Conner-Rustan procedure. Dr. Ruszewski will talk about that. And we can do a Ross-Conner procedure. And we can do bypass procedures. We can bypass the stenosis in a node procedure, Demus-K-Stenzel, or Yasui procedure. So this is an echo of an isolated subaortic stenosis. You see this fibrous membrane underneath the aortic valve. Here is the aortic valve, and here is this fibrous ridge. So our own experience in isolated subaortic stenosis over the last 15 years were 12 patients. 9 had a discrete fibromuscular stenosis, 1 had a tunnel type stenosis. In 11 cases we did resection plus myectomy. In one case, we did a modified Connor procedure, and the results were as is shown on this slide. The 11 patients with resection and myectomy, there was no mortality, there was no AV block, but 2 patients needed a reoperation for subaortic stenosis, one 6 years after resection and one 13 years after resection. In the first one, we could resect it again. In the second one, we had to do a Ross-Connor procedure 13 years after resection of subaortic stenosis. The one patient with the Ross-Connor procedure is still without recurrent subaortic stenosis. So these are 16% of reoperation rate. This is consistent with the international literature. Our experience in hypertrophic obstructive cardiomyopathy is very small because we are an exclusively pediatric unit. We have only 2 patients. Both patients survived. Both patients did nicely afterwards. One patient needed a reoperation after 12 years. More interesting is the subaortic stenosis in complex malformations. And we had 57 patients in which the subaortic stenosis was a critical part of the malformation. That means that the subaortic stenosis had to be treated during the initial procedure, during the initial repair. 8 patients had this complex of VSD posterior malalignment, VSD of the conus septum, VSD coarctation, VSD hypoplastic aortic arch, and VSD interrupted aortic arch. 29 patients were complex transpositions, and 20 patients were critical aortic stenosis with subaortic stenosis. So what did we do in the complex of VSD posterior malalignment of the conus septum? In 4 patients, we did a modified Connor procedure. That means we cut the conus septum up to the aortic valve and so enlarged the ventricular septal defect to get a wide left ventricular outflow tract. In 4 other patients, the aortic valve annulus was so hypoplastic that we had to replace the aortic valve, and we did a Ross-Connor procedure plus aortic arch repair. In the complex transposition, in one patient we did an arterial switch operation and did a similar procedure as in the VSD group. We did this modified Connor procedure, incising the conal septum up to the pulmonary valve in this case. In 11 patients we did a Rastelli procedure, and in 16 cases a so-called en bloc rotation of the truncus arteriosus. This is a form of aortic translocation similar to a Nikaido procedure, but we could keep the pulmonary valve. And the critical aortic stenosis with subaortic stenosis was treated with Ross-Connor procedure in our unit. So these were the results, and the most interesting thing is, of course, of this presentation is the reoperation rate for subaortic stenosis. The Rastelli procedure in transposition of the great arteries with left ventricular outflow tract obstruction. We lost one patient. This was a patient with a very complex form of this malformation. He had not only transposition plus VSD, but he had also a common AV canal, left ventricular outflow tract obstruction, right atrial isomerism with we did not see any AV block, and interestingly, in our Rastelli series, we did not have any reoperations for subaortic stenosis. The same was with the en bloc rotation of the truncus arteriosus. We had one pacemaker 3 months after the operation for an AV block of 2nd degree, but we did not see any reoperations for subaortic stenosis. In the 5 modified Connor procedures, all these patients survived. 2 patients needed a reoperation for subaortic stenosis after an interval of 2 years. So we could resect this subaortic stenosis at that time. Both patients are doing well now. The 24 Roscono procedures, these were all borderline left ventricles with critical aortic stenosis and PDA-depending systemic circulation. We had 2 early deaths and 1 late death. The late death was a death for mucormycosis after an abdominal procedure, colectomy. The other ones died, 1 for sepsis and 1 for mitral stenosis. 1 patient had an AV block, but no patient needed reoperation for subaortic stenosis. This is our experience in patients with subaortic stenosis after complex malformation. 4 patients with after an AV canal repair showed subaortic stenosis. Interestingly, almost all of these patients did not have a normal, simple AV canal, but had some more complicated form. One of them had a tetralogy with AV canal, one of them a DORV with a common AV canal, and one of them an AV canal with a coarctation. 2 patients had an arterial switch operation. The 2 patients with the status post-PA banding were referred from other centers because in our institution this is a clear indication for a primary Norwood procedure. So what were the results after these problems? 6 patients, we could do resection plus myectomy plus mobilization of the mitral valve, papillary muscles plus resection of accessory tissue. This was done in 1 of the AV canal patients, in 2 patients after an arterial switch operation, and in 1 patient with DORV after a single ventricle palliation. The Rastelli patient was also referred from an other institution. It was not our initial Rastelli. 1 patient had a resection after a status post-mitral valve replacement in the first year of life. 4 patients had a modified Conner procedure, and in 2 patients, these were the single ventricle patients, we did a bypass procedure, a Demus-Case Stansel procedure. The results are shown in this slide. After myectomy, we had 1 patient who needed a reoperation 12 years after the initial resection. This was the patient with the single ventricle and DORV. The modified Conner procedure showed 3 patients needed a reoperation, 3 patients out of 4. May be that at least 1 of these patients was a technical problem, but this was a little bit disappointing about the modified Conner procedure. And the Demus-Case Stansel procedures went well and did not come back for subaortic stenosis. So, to answer this question, from our own experience, we can say that the isolated subaortic stenosis and maybe the subaortic stenosis in hypertrophic obstructive cardiomyopathy seem to respond quite well to resection. However, resection should never be alone. It should be with myectomy, at least myectomy, and resection of all accessory tissue and mobilization of papillary muscles and whatever is in the way of the blood flow. Other forms of subaortic stenosis, especially in complex malformations and after repair, usually need more, either a patchplasty or a bypass procedure. Thank you for your attention.